I'm just going to hand over, before I go on to the agenda, I'm going to hand over to Jenny Skipper, who's going to outline the housekeeping arrangements for today's meeting.
Okay, thank you. Thank you for logging on to this Zoom video conference of the Healthy Communities and Adult Social Care Scrutiny Committee. I am the Democratic Services Officer for this meeting, and I'm assisted by my colleague, Kate Sheldon, who is the host of the virtual meeting. We will proceed to introductions and housekeeping in a moment, but just a couple of points to note. This meeting is a public meeting and in alignment with the new regulations which permit meetings to be held by remote means will be live streamed for the public to view. Sheffield Live have also said they wish to record parts of this meeting and will broadcast it. To make the meeting run as smooth as possible, can I please ask that participants in the virtual meeting room to leave your microphone on mute when you are not speaking. When you want to speak, please raise your hand to the camera. Only unmute when the chair indicates that you can speak. If at any time any member loses the ability to hear or be heard, they must alert the chair or host as soon as possible. You may see members looking to the left and right of their screens. This is because they may be looking at an additional screen or device containing the agenda papers, not because they are distracted. I will now hand back to the chair of the meeting.
Thank you, Jenny. I'm going to go around now and ask people to introduce themselves. So we have a combination of people here, councillors and observers who are members of the meeting, and we have some guests as well who are here to contribute to a particular item on the agenda. So I'm going to ask people to introduce themselves in order of how I can see them on the screen. So Emily, please.
I'm Emily Stanbrook-Shaw, the Policy and Improvement Officer from Sheffield City Council. I support this scrutiny committee.
Councillor Jane Dunn.
Jane Dunn, Councillor of the Southey Ward.
Jenny, you've already introduced yourself. I shall pass if you don't mind. Councillor Crockett.
Good afternoon, I'm Councillor Julie Groke, Stocksbridge and Upton Ward. I'm a substitute member for Jackie Satter.
Thank you, Julie. Vic Bowden, please.
Vic Bowden, Councillor for East Ecclesfield.
We've only got one Sue, so Sue Holston, please.
Hi, I'm Sue Alston, Councillor for Fulwood Ward.
Martin.
I am Martin Phipps, Councillor for City Ward.
Lucy.
Lucy Davis, Chief Officer of Health Watch Sheffield.
Thank you, Lucy. And Adam, please. Adam, could you unmute, please?
Yes.
I don't usually have to say that to you.
I record it every time you say it. Yeah, Adam Hurst, Councillor for West Ecclesfield.
Gary, please.
Councillor Gary Weatherall for Shade Green of Brightside Ward.
Angela.
Councillor Angela Audencio for Broomhill and Sharrow Vale.
Lewis.
I'm Lewis Dagnall. I'm a Labour and Cooperative Councillor for Gleaders Valley Ward.
Steve.
Hi, Steve Aris, Councillor of Grays Park Ward. I'm Deputy Chair of the Scrutiny Committee.
Thank you. Mike.
Mike Drabble, Councillor for Richmond.
Talib.
Talib Hussain, Councillor for Bangry Ward.
And two of our guest speakers today. Zach, please.
Yeah, I'm Zach McMurray, GP and Medical Director at the CCG.
Nice to see you again, Zach. Long time no see again. Yeah.
Oh, wow.
Yeah, and Sandy, please.
Hi, thanks. It's Sandy Buchan, Director of Commission Development for Sheffield CCG.
That's great. Thank you very much, everybody. Oh, and Kate, sorry, I missed you because you're on the other side of me. Kate.
Sheldon, Member Support and Civic Manager, host of the meeting.
Thank you, everyone. Do we have any apologies for absence?
We've received apologies from Councillors Jackie Satter and Councillor Julie Groke, who is subbing for it, and also from Councillor Gail Smith.
Thank you. Now, do we have any, as far as I can see, there are no exclusion reasons for exclusion. Has anybody notified you of any, Jenny? No, so there are no items on today's agenda which require exclusion of public and or the press. Moving on to declarations of interest, do we have any interests that need to be declared at this point in items of the agenda that are on the agenda today? we're all interested in general terms, but this is a bit more official than that, so that's fine. No declarations of interest. And moving on now to minutes of the previous meeting, which took place on the 11th of November. So first of all, are we happy that these are an accurate record, or does anybody want to comment on them? Can I take these as an accurate record then? Somebody want to move? Yeah, thank you. I'm going to go through them page at a time, fairly swiftly. Just put up just indicate if you've got anything that you want to say in terms of matters arising. So I'm starting off with page 9 on your agenda pack. Page 10, 11, 12, 13, 14, 15, 16. Emily, please.
I just wanted to highlight that at 6.7c, the resolution that the chair write to an organisation, the appropriate organisation, about the data on ethnicity of people turning up to test centres. At the meeting, it was reported that that information wasn't being shared. It became clear when we followed it up that it recently had started being collected. So we haven't actioned that one because it was unnecessary.
Yeah, thank you for that, Emily. And you did send around an email just clarifying that that was the case. Anything else on the minutes that anybody wants to raise? Otherwise, we'll move on. No. Great. Okay, we've got our just one main item on the agenda today. Oh, sorry. I understand we haven't received any questions or petitions. Is that correct? Yeah. Okay. Thank you. That's why I didn't immediately raise it. We've got one main item on the agenda today. Primary care and community care, and as the committee members will know, what we've actually been doing this year is working through a whole range of key services and so on, and particularly looking at how they performed during the COVID pandemic, and also what the situation is now. So I'd like to welcome today Dr. Zach Murray and Sandy Buchan, who are going to introduce this item. We've previously circulated quite a lot of information, and they're not going to go through that with us this afternoon, but I'll give you the opportunity to make some introductory remarks, and then I'm going to hand over just briefly to Lucy Davis from Health Watch, because you can see we've got a paper from Lucy, and I think we'll take those both together, and they really complement each other quite well. So Zach or Sandy, who would like to go first?
I will start and I'll ask my colleague Dr. McMurray to chip in as we go through. So we did circulate a set of slides in order to inform this item. But I would say that the main points that I wanted to pull from them is that during COVID, especially during wave 1, the CCG led the response in primary care. Fully supported primary care in partnership with our federation, PCS, Primary Care Sheffield, and during that time incorporated a number of functions. We did invest an amount of money, which we continue to do to meet the needs, and obviously ensure that we gained feedback from patients and population in order to see how that was working. But basically the functions were very much developed and supported with the practices themselves to ensure that they did remain open, functional, and did everything they needed to do during the wave 1 and continue to do during whilst we're in wave 2 and continue through the pandemic. So the first point I really wanted to make was the amount of support and infrastructure we put into primary care during that time. And as you see through the slides, there were a number of elements such as IT, such as the setup of services to ensure that primary care was functioning to where we needed it to be during COVID. A second point I wanted to just pull out was during that time, obviously the whole NHS faced a number of challenges. And that wasn't unique just to primary care. So one of those challenges very much being the amount of national guidance that came through on a very quick turnaround basis that we did support primary care to interpret and make sure that locally we implemented that and ensured it met the needs of the Sheffield population, which being the main aim of what we were doing during that time and continues to be. There was some frustration in regards to that, but obviously that is something we very much supported primary care throughout, and again, like I said, continue. The last point I wanted to make in regards to the slides was actually the feedback that we've received both from the practices and from the population and patients has very much been used and continues to be collected and collated to ensure that our future working, our future commission intentions looking forwards, obviously through the next few months, as well as beyond, very much informs what it is that we need to do and continue to support primary care in delivering and achieving. So it was very much wanting to articulate what we've done, what we continue to do, the challenges that we face, but also how we're using that information and engagement in order to inform what we want and need to be putting into place in primary care going forwards. Dr. McMurray, I'm not sure if you want to add anything more into that.
Yeah, I think just really to stress that primary care is beyond just your local practice. So it was community pharmacy, community services, all working together to try and get the primary care response. Just as a sort of off the top figure, general practice manages about 90% of the activity within the NHS, and that activity has been increasing by around 10% each year for the last 10 or 15 years. So practices already were getting quite busy. But on top of that, during COVID, we've seen probably a 25–30% increase in activity that practices are doing. It was very clear from the outset that we had to limit our face-to-face contacts. Two reasons for that. I mean, the virus itself is very infectious. So clearly a general practice setting could be a vector for passing on infection quite rapidly. Many practices were already using telephone triage or telephone consultations. We rapidly moved to video consultations, and the infrastructure to get the technology behind that was quite difficult, but we coped pretty well. I think that's something that will continue into the future. So we're getting high levels of patient satisfaction with the telephone contact, but also the video consults. It can be much more efficient from the patient's perspective. It takes probably a similar time from the GP perspective, but gives you the opportunity to have clinical photographs that can be added straight into the records, which then aids the pass on into secondary care. Working together was really important. So our community pharmacies played a huge role throughout COVID, and we've got a very close relationship with community services and with secondary care. I think if anything during COVID that was enhanced quite markedly. So I think the comment I would make is that a lot of our practices are evolving quite rapidly into using technology much more. And I think what COVID did was actually accelerated that. Things are still very busy, and we've now got the added task of doing both flu jabs, which we're just sort of finishing at the moment, but also the COVID vaccine, which is clearly the game changer in the fight against COVID. And general practice will be fully involved in the implementation, the rollout of the COVID vaccine. The big opportunity there is the Oxford vaccine, which we're hoping will be approved in the next couple of weeks. And that can be used very much as a flu jab. So is the sort of the bread and butter of general practice, which means that we can hopefully roll that out quite rapidly and get the high risk population protected very quickly. So it was really just to stress it was a joint effort during COVID. It's still very busy. Practices are under a lot of pressure. Practices are getting a lot of the frustration from the public, which has always really happened because we are sort of front line. And as a GP, it's not me that gets it, it's usually reception staff. So we have had a lot of frustration that's been boiling over, largely due to restrictions and some issues around COVID that are without the control of the practice, and practices can't really do anything about it. But I think stress levels within the general population are pretty high. So I think that's probably all to add at this stage, and maybe open up for any questions or comments.
Well, won't take questions at the moment, but thank you. Hang on, Steve. Thank you for that. Just to say, they were still expecting Nikki. So what I'm going to do is I'll bring Lucy in now, because she's going to feed in a different perspective, and we'll give Nikki an opportunity to contribute if and when she gets through. So I'll go over to Lucy, but I've already got Jane and Steve who want to ask questions.
Thank you, Kate.
Sorry, Lucy.
Thank you, Kate. So we always hear quite a bit about primary care at Health Watch, and a lot of that actually is positive, and that continued to be the case during COVID. We heard positive stories about people who felt that their surgeries had made changes in the building that made them feel safe when they had to visit or had cause to visit. For some people, digital consultations and the shift to phone appointments was a positive thing, for example, if they had childcare responsibilities. But inevitably, there are also groups for whom those changes haven't worked so well. And we've heard a bit about that. So, for example, people who can't access by phone because they might not have credit on their phone. We've heard quite a lot from deaf patients, actually, people in the deaf community, about the barriers that particularly phone triage places for them. We ourselves identify that we've got a bit of a gap in that we haven't managed to speak to many people who have English as a second language or who really don't speak English to find out what their experience has been. But we have heard a little bit of feedback to say that it's quite hard really conveying the sort of situation that you're in sometimes over phone as part of a triage process. So I suppose the sort of takeaway line that we'd say from that is that probably there's a bit more delving needs to be done in some of those groups as we're moving into like maybe more permanent changes, and some of these changes are being kept. We really need to focus in on those groups who are potentially excluded by those changes to make sure we understand more about their experience and what needs to be done to sort of mitigate against them being excluded from the care that they need. I've heard some things about pharmacies. I think actually some of this sort of sorted itself out a bit. I think this probably related to the earlier days of the pandemic, when people were a bit confused about sort of changes in processes and how they could actually get their prescription, and particularly people who were shielding. There were some complications around that, but we've heard less about that recently. So I get the sense that's perhaps improved for people. So I think those are probably the main. I think that the takeaway thing that I would want to say really is, if we're making changes, we really need to focus on the groups that we know are potentially impacted in different ways by those. So I feel like that's kind of been started, and I know that the CCG have done a lot of engagement work to get some of the bigger picture stuff, but probably there's a bit more deep dive stuff that needs doing for some of those groups.
Okay, thank you very much for that. Just to remind everybody that the reason that we're doing this isn't because necessarily we think there are problems, but some of the issues that you said, Zach, this about we get them as counsellors, frustration with primary care and so on. This is a real opportunity actually to put the record straight, for people actually to be able to ask questions and for you to be able to respond in the public domain and so on as well. So that's what we're hoping to achieve today. I've got 4 people: Steve, Jane, Gary and Sue, who've indicated that they want to question Angela. And people can come in later, it's not your only chance, but I've got those 5 to start with anyhow. So Steve, would you like to start then? And please feel free to ask questions or make comments today, because we've just got the one item. I'm not going to hurry you along to the same extent, but I will if you take too long.
I'll be quite brief. Yeah, in many ways, Lucy stole my thunder, because I wanted to ask a question about the use of technology, and obviously a lot of the vulnerable groups, particularly the elderly, aren't particularly used to the use of technology, and I do feel that there is an issue with how that what is available out there is communicated to people, and the way it is communicated, because despite telling people that you can have a consultancy online or use the phone or that, a lot of elderly people particularly don't take that in quite so quickly as younger people. I just wondered what was in train in order to address that particular group. So in many senses, it's something that Lucy's already referred to.
So who would like to take that on?
Do you want me to respond, Sandy?
Yes.
I would probably include myself in that elderly group that's maybe not as IT savvy as the youngsters. I think all of us tend to sort of learn IT at a different rate. I'd also say, though, that actually quite surprising that quite a lot of patients in that older group are actually quite good with the technology. So I guess the thing is not to make any assumptions. So my, certainly with respect to my practice, we would always put ourselves in a position of having a consultation that the patient's comfortable with. It's difficult because we're talking about technology, and I'm going to say, well, it's advertised on the practice website, but clearly if you're not able to access the website, I think what we're trying to do is all the practices on their websites will be clear about the different types of consultations that are offered. So effectively, if a patient needs a one-to-one face-to-face consultation during COVID, it would have happened, and that option was available. Now, obviously, maybe some practices didn't quite stress that to the extent of others. So we certainly encourage practices to be very clear that they were there to, as a clinician, you've got to put yourself in a position where you can make the decision about the patient. And part of that is how comfortable the patient is with the method that you're using. So I've had telephone consultations where it's been clear that it's not going to work. So you bring the patient in, put the PPE on, have the proper conversation and examination. Clearly, if you've got to examine patients, you have to see them face to face. The other bit we did was actually did quite a lot of work with our community nurses who were still seeing patients, and with the voluntary sector to try and get the message out there that your practice is still open. We did a lot of comms around that, so we did things in the local paper. Again, it's a website, with the CCG website had information about that. So the message we tried to get out throughout was your practice is open. The reason the door's closed is for safety of the individual, safety of the staff, because clearly if you get an infection within a practice, it's a major issue. So I think we tried to do as much comms as we possibly could. Part of the problem was obviously the COVID pandemic probably caught us a little bit by surprise in how quickly it sort of came upon us. I think people were expecting it, but it all happened quite quickly. So there was a need to act quickly that probably limited the comms that we could get out as quickly as we'd have liked to. And I think the thing going forward is that what we're really encouraging practices to do is use the other methods where they're appropriate. So effectively use it as part of the offer that you now give to your patients as you start to open up more and you do more face-to-face contacts. And it's interesting, within the practice I work in, we're finding by far the majority of patients like to have the telephone call and try that first, like to have the online consultation. But we're absolutely clear that, if you need to be seen, you'll be seen. We'll bring you in, we'll put the gear on, we'll see you. Now, it's a lot easier now. The other issue we did have at the beginning of COVID was that we did almost run out of PPE, which would have put clinicians in an absolutely impossible situation. So do you risk seeing a patient without PPE, potentially putting yourself at risk? And I think most clinicians would. But also you put the patient at risk, or you put the next patient at risk by doing that. So the PPE crisis was a major factor that I think shouldn't be overlooked, and put many of us in a position that we probably weren't able to see patients that we would have liked to see, because we had to put that threshold quite high. Now, obviously, PPE is now readily available, and we're in a much stronger position. So I would like to think that most practices are able to just lower that threshold and give more options to patients.
Okay, thank you for that.
Thank you for that. Thank you.
Yeah, thank you for that. Sandy, did you want to come in on this as well?
I did, yes, thank you. I just wanted to briefly say that I think right at the start we recognised the levels of people who had access to digital technology, as well as those who were able to use it. And we very much worked with practices to understand how to best get communications out, whether or not, as Zach said, in terms of newspaper or radio. And I think we've definitely recognised the inequalities issues, with this being one of them, and collated the figures. So in our future planning and strategy in moving forward in the use of digital technology and how we see patients in primary care is very much a factor as part of our commission intentions moving forward. So it is something we recognise and want to work with going forward, but obviously that we want to work with our practice and engagement with the population to make sure we get the best comms in the best way to them.
Thank you, Sandy. I've got Jane next, Councillor Jane Dunn.
Thank you. Thank you. Yeah, well, my question, which is what Lucy touched on, was about those that are excluded, but I'm going to push on that a little bit further. We all know, I mean, I've been lucky enough, I've had quite a few medical, and I've had it, been in the surgery, and I've done it digitally. And I've had a video one, which was really, really good, do you know, to be honest with you. I was just wondering, with the people that you do know in your practice, that you know are vulnerable and emotionally vulnerable, you know, kind of, what measures are you putting in place? Because a phone call or a video one is not the same. You know, kind of, and people now, we were talking about this in ourselves earlier, about how 10 months in, people are now reaching a level of breaking point, do you know, and so really, how are you as practitioners preparing for how the small things could escalate, and how we're going to keep people, do you know, together on that? Because it is, you know, the thought of the vaccine is absolutely amazing, and it's wonderful hope. But it's also, I think today, when I've been talking to people, it's also made them feel quite panicky. So it's actually, how are you going to handle that and make sure that these people that are emotionally vulnerable don't fall through the cracks? How are we doubling up with our housing departments, do you know, that might be having other reasons to visit these vulnerable people? Are we sharing that information? So it's kind of, it's a really, really off the wall question, but it's one that's that's been approached to me a couple of times over the last 2 weeks. So I'd just like to know what we are doing with those vulnerable people, and if we're using other services, do you know, to help keep an eye on them, inverted commas.
So I think there's probably several sort of facets to the answer, really. I mean, I'm a bit of an old-fashioned GP, and I think the continuity of care and the family doctor and the doctor that knows the family is very important. So it's a relationship type thing. So we encourage practices, and I think most practices in Sheffield do, to try and do the continuity bit. So try and get the same GP, particularly with mental health issues. It's really good to have the same GP that looks after you, if at all possible, particularly through an episode. So I think most practices tend to do that. It doesn't matter so much who you see, if you've got a cough or you know, chest infection or UTI or whatever. But if it's an ongoing problem, then it makes sense from a practice perspective around a quality of care bit, but also around the patient's confidence perspective for you to see the same doctor. So effectively, you book the next appointment when you see the patient. I think you're back into the technology bit. It depends on the individual. Some people with mental health issues find it easier over the telephone because they struggle a bit with the face-to-face. Some people find it easier doing the accurates, the sort of video call. Some patients, it's clear that face-to-face contact is really important. And I think, again, it's the judgment, some of it being the judgment from your previous experience of the patient. So you might say, you know, I'll bring you in and I'll see you. Or it might be that you just give the patient the opportunity to say whether they're comfortable, or it comes down to you sense it with patients. You know how the consultation's going and you'll flex it. So I think there's that bit, which is the individual practice bit. I think on the back of it, there is a feeling that there's massive collateral damage from COVID. I think a lot of GPs would say probably more collateral damage than COVID damage. And the collateral damage particularly is around mental health issues. So I think there's much more awareness that people are struggling. So I think that probably changes your threshold for managing people. We do have quite a good system in Sheffield. We've invested more than most areas in mental health. So as a GP, I've got a lot of alternative support that I can use, you know, whether it's through the traditional mental health services, the voluntary sector, counselling and CBT services, so your psychological therapies. We've over-invested compared to most areas around that, and that's really helpful. The other bit about joining up services, the practices now all sort of sit within a primary care network. So practices much more than ever actually work together. And part of the network is to work with your local services. So I think that's created stronger relationships with community services, but also engaging with your local voluntary sector, your schools, your housing. Now, some of that was sort of held back by COVID because obviously everybody's just flat out doing COVID, but also some of it blossomed under COVID because there was a real need for people to work together and share some of that intelligence. So I would say in some areas we're probably further on than we were before. In other areas, I think there's still work to do to build some of these relationships. So I think it's probably it's a complicated answer to a complicated question, is probably the way to put it. I think we're in a better position in Sheffield than most areas, but there's still work to do.
Now sorry, Chair, may I just have a follow-up on that? How are you sharing best practice on this across? Because, you know, that's really, really important to me, that surgery, you know, practices that have had really good, you know, kind of experiences are sharing that with others that maybe are a bit hesitant about trying it.
Yeah, again, through the primary care networks, they meet on a regular basis. So each network has a clinical director who's usually a GP, but sometimes nurses or other practitioners who have got a bit of protected time. And they're almost, I would say, the coordinators of the care across that network. The networks also meet on a fortnightly basis. So all the clinical directors meet together on a fortnightly basis. We've had a lot of success in Sheffield, particularly around mental health, with our protected learning initiative. So we set up training events, and we've continued some of them during COVID, obviously through alternative technology rather than face-to-face. So I think there's a track record of sharing experience in Sheffield. And what we try to do is, if we've got practices that are perhaps less willing than others, what we tend to do is try and target them and go into the practices and talk to them and try to encourage them to share some of the knowledge across the patch and some of the learning from other experience and practices. So again, there's always work to do, but I think we're in a much stronger position in Sheffield than other places.
Thank you, that's really reassuring. Thank you.
As a supplementary to that, I don't know, Sandy or Zach, obviously you've talked a lot about the way you work in teams, basically, in different sorts of teams. I just wondered whether or not there were any particular challenges caused by COVID in terms of bits of the whole system that worked well and those that became fragmented actually during response to the crisis. Were there any did you identify any real weaknesses in the whole process in terms of not necessarily primary care, but some of the people that you need to work with in order to, to have a whole system approach to the needs of the population?
I think probably going back to the thing around the PCNs, and they were developing quite rapidly. And one of the big things is to try and get the voluntary sector involved at PCNs. And I think probably because of the fact that everybody was flat out, some of that probably slipped. So I think that's one of the priorities, is try and pull the local voluntary sector support in so that GPs are aware of what's available, but also build the relationships, get that sort of mutual understanding about what each part of the system can do. I think the other thing was that I think our community services probably felt a little bit isolated because they by necessity still had to do face-to-face, and we're out there doing it. There was a strong message that came down that GPs had to stop doing face-to-face work. And there was also a strong message that we had to keep patients out of hospital. And again, we were concerned that might actually make the community service feel isolated, but also end up with patients not getting care. So we got a lot of messages out quite early on that wasn't the case, that we had capacity in hospital. If anyone felt a patient had to be admitted, they should be admitted. But also community services can still call their GP, speak to them, and if need be, the GP will come out and do a face-to-face consult. So I think that was probably one of the areas we came aware of, but I think we corrected it quite quickly because again, there are strong relationships there across the practices.
Okay, thank you for that. Gary, Councillor Weatherall, you're next.
Yes. Oh, now I'm getting a lot here. Thanks, Chair. Good afternoon, everybody. Just a couple of things. Canada's just approved the vaccine now, so that's good news. Just what's really bothered me today, Chair's already took one of my questions, but she didn't know we were going to ask it, of course. But it's been on BBC today, and lots of people, in fact, I was stressed out. I didn't go out for 16 weeks when it first happened. And I only went out because doctors told me to go in for an MRI scan. So I can understand about anxiety and everything, but the world's got to go by, and GPs are going to get the blunt of it, which you have. I've heard lots of stories. But today, which is very upsetting, really, when you know that children are away at universities and they're being really stressed. And I just wondered how that's going to impact on education in this next year, 2 years, 3 years to come. Because if you're stressed out at this time to go into exams, which you always are anyway, but long term, how are we going to put that together?
I think it's a big issue. I mean, I do feel sorry for children and young adults nowadays. I think it's a lot more difficult and complicated than it was nowadays. There seem to be a lot more stresses that we didn't have, so your social media and all that sort of stuff. I was also quite concerned that I think a lot of the young people were probably demonized around COVID. And some of the press coverage I thought was particularly unhelpful. I think there were some people, and I saw it across the whole spectrum, some adults, some actually quite vulnerable older people that didn't follow the rules. But I think the press kind of honed in on the students. You know, we did have a spike when the students came back in Sheffield, but we expected it because you will get a spike because you bring in people from outside. So in a pandemic, that spike would happen. I think some of the behaviours that were probably shown in the press were not quite as extreme and as common as we were led to believe. And I mean, my daughter's she's a student in York. Although she was one of the ones that did follow the rules, she said that they actually got a lot of abuse from people when they were out in the streets and stuff, that, you know, they were assuming that they were the ones that were causing COVID. So I think the press coverage was appalling. It was really unhelpful. The problem with kids, I mean, young adults of that age, is that a lot of the things that they experience stay with them for the rest of their lives. So I am concerned about that. I mean, you know, going to university and getting an education is really important, but also the meeting people, the social aspects are equally as important. And I do worry about that generation that have lost out on that, because I think it's really quite important in forming you for later life. So, I mean, all we can do is be aware of it. I think we need to lower the threshold. I think as clinicians, we make ourselves more accessible. I think we use the good services that we've got in Sheffield, because again, we've got a lot of services for young and sort of teenage and into young adults that wouldn't be available elsewhere, particularly around psychotherapy. So our access for psychotherapy is really good. I know in Derbyshire, where I also work, you're waiting nearly a year to get an assessment, whereas in Sheffield, it's about 6 to 8 weeks still, because we've put extra capacity in. So I think that's all we can do. Some of the other stuff, it's other parts of the system doing their bit as well. You know, so how do you reduce some of the stress in the kids? And, you know, some of that is government, some of that is schooling, education. Some of the stuff I talked about around PCNs working together. So we can exert some influence on education in Sheffield, and certainly within the Outbreak Control Forum that I'm involved in. We've got the universities involved there. You know, it's felt very cohesive and supportive. But yeah, absolutely. I think kids are damaged. I think that's inevitable.
Okay, thank you. Councillor Sue Alston next, please. And I've got you, Mike, as well. Okay. Sue first, please.
Thank you. I've got a few questions, but if that's okay, Chair.
Yeah,
my first two are sort of fairly sort of succinct, based on stories, I'm afraid, or things I've been told, made aware of. So the first thing is people who need, I mean, in the particular case I'm thinking of, it was actually a practice nurse appointment for a practical procedure. and somebody being told that they need to travel to a different practice than their normal practice, but not being offered any means of getting there and nobody checking that they could. And I just wonder how much, I mean, I know I saw in the report things about, well, there was a taxi service available or something, but clearly this particular individual wasn't made aware of that, and actually by the sound of it, ended up quite distressed. So I just wondered how much we were actually communicating the offers that were there. And another thing that concerned me a little bit was, again, a case I heard about was of an elderly person being given an appointment to attend the practice, and then being asked to wait outside, which was okay, they had a car to wait in, but, you know, I mean, it's not so bad in summer either, but you may need to sit down. So just little things like that about thinking about the individual. My third point is in the reports, there are concerns around people whose English is not their first language, and the fact that they seem to have found it more difficult, which I suppose we could anticipate really. And I just wonder whether some of that was down to misinformation being circulated, or whether it was down to failure to communicate via appropriate channels. And I just wonder if there's anything we can learn from that, about getting information through to people when services need to change. And then my last question is actually about DNR forms. I know there's been a sort of, I think there's been a national investigation about the use of these forms within care homes. And I just wondered whether there was any local information about their use in care homes or domestically. I am aware of somebody, an elderly person, not in Sheffield, I hasten to add, who was asked to sign one very early on in the pandemic because, quotes, they wouldn't want to take up a hospital bed that a younger person could have, unquote. And I just wondered what we knew about the position in Sheffield and also what learning we've got from that. Sorry, that's quite a lot, but.
Okay, I mean, there's some sort of general points in there as well, aren't there, about communication and, you know, people, I think that's quite a big theme actually in Sue's question. So, so who would like to start off? Sandy, Zach?
If I just start off in terms of the engagement and communication aspect, I mean, as Zach pointed out earlier, you know, this happened quite quickly, and there may be individual cases that possibly we weren't aware of, that we needed to pick up on certain things that happened. And learn from them, and as we did in wave, what we learned in wave 1, we tried to incorporate in wave 2, and especially that as part of the engagement and communication with people who weren't necessarily could see the internet or the social media pages that the CCG have got. But it's definitely something that's a priority of ours, to learn from the experiences and gather these the stories and the concerns in terms of what happened. And also we're aware, and as Lucy pointed out, in terms of the gaps with the certain areas of the population that we need to get stronger in. And I think being aware of that and making sure that we do incorporate that within our work going forwards, I think is definitely what we're wanting to do. Obviously, if those things have happened for those particular patients, then without looking into that, obviously I can't understand the rationale behind it, but we certainly worked with our primary care colleagues to ensure that patients' safety and wellbeing were absolutely at the heart of what, however procedure or process they needed to undertake to ensure both the practice staff and the patients were safe during each of the waves. So I think it's learning, it's listening to those stories, those comments, and making sure that we've got a plan going forwards. So that for me, it is a learning curve. And as Zach said, you know, this came upon us very quickly, and we really needed to put things in place to keep everybody safe. And that was absolutely our immediate priority. But we tried to put things in place, such as the taxi service, as you said, once we knew that there was an issue.
Thank you. Can I just clarify before I bring Zach in? Is the taxi service to another practice something which is routine, or was this sort of is it an exceptional part of the offer? I suppose, you know.
This was an exception part, especially in terms of the hot hubs, which was for COVID patients who had COVID symptoms that we identified was an initial risk and safety issue. There was a number of things that we put on, and obviously, you know, taxi services and transport is an issue that is looking at. So we wouldn't necessarily be looking at putting in taxes for the future, but we would look at transport in general with our local authority colleagues as to how to best utilise that approach. But again, it's trying to resolve something that we knew was an issue in that moment, learning from it, and then making sure we've put something efficient financially as well as effective in terms of safety as in place in the future. So it's all about learning and making sure we've recognised what worked well, what didn't, and how we can utilise that as approach going forwards.
Thank you. Zach, did you want to come in on those Sue's questions?
Yeah, I think it was really important, and certainly to start with the COVID, we had to really be careful of getting any potentially infective patients into the practice. So that was the necessity around some practices having closed sites. Some of it was also around staffing issues. What I'd like to think is that someone within the practice would have the conversation with the patient that checked that the patient could actually get to the other site. Now, I accept that in some circumstances that might not happen, but you know, the transport was there, and it should be possible to do that. I think a lot of it, I think quite often it is around communication or poor communication. So there are a lot of things. I mean, for instance, I do joint injections within the practice, but we were told that we couldn't do them because the fear was that the steroids could potentially make you more prone to have bad effects of COVID. So we were instructed not to. We were told we wouldn't have any indemnity if we did it. Now, when you say that to a patient, then you can sort of quell some of the anxieties about, I need my injection. So I guess it's how people communicate that's really important there. The bit about the elderly patients outside, so the standard operating procedure that we were sent as practices was that you should close your doors. You should have an access system where the patient talks to you, and you should only be bringing the patient in for the time that you need to do that contact. You need to minimize the contact. Now, again, I would like to think the practice has used a bit of common sense. Most practices have got some place that a patient could sit. So what we did in my practice is that if the patient could safely stand outside, if the weather was decent, if they had a car, if they had some place that they could stay, in the practice, we actually put a little covered area. But at all points, the patient was asked, are they comfortable doing that? And if they weren't comfortable, they could be brought inside and they could wait inside. The downside of that is you've then got to disinfect that whole area. So clearly it then limits how many patients you can have in at any one time. And even if you disinfect the area, you are introducing an infection risk within the practice. The other bit that was really important is that the red patients, as we call them, which sounds awful, but the potentially COVID positive patients were kept away from the normal routine patients, again, to try and reduce the risk of cross-infection. So again, it probably made it look a little bit draconian with what practices had to do, but we were told to do it. But also, I do think it makes sense, because if you got an infection within the practice, you'd effectively close the whole practice for a period of days, if not weeks. So it was very high risk at that time. So it was a balance between the individual and the needs of all your patients, I guess, is the way I'd put it. The final bit around the DNA CPR, there's no excuse for that not being done properly. There was pressure to keep patients out of hospital. We were concerned that some of the national pressure was probably putting clinicians in a difficult position. So we got a joint message out very quickly through the colleagues at SDH and the other hospitals that they were open for business too. And that if any clinician felt a patient had to go in, they should go in. The blanket DNA CPR that people talk about, very little evidence that that's happened in Sheffield. I'd like to think it would absolutely not happen, because it's a disgrace if it did. What we do is actually monitor the numbers of DNA CPRs that are put in. We've got registers for patients who are on end of life, and part of that is how many are actually having a DNA CPR put in place. And we know that the numbers increase slightly, which is what you would expect, because it makes sense when you come into a pandemic to have these conversations. but none of the spikes that they've recognised elsewhere in the country that's actually triggered the review. And we've been selected as one of the random areas to have the review, and I met with CQC yesterday and the day before. And the feedback we've had so far is they're very happy with the procedures and the information that we had in place. And they haven't as yet found any evidence of poor practice.
And so did you want to come back on that?
Yeah, I mean, I just want to say from that last point of view, I'm really very pleased to hear that. I mean, if I didn't make it clear that, because I can't remember whether I did or not, the example I knew about was outside Sheffield. Yeah. So yeah. I am very pleased about that. And as you were saying about the other points, it is, I think, very much about communication and making sure that people know what to expect before they turn up, really, and can make plans for themselves. Yeah. So yeah, that's good. Thank you.
I mean, I found when you explain the rationale behind a lot of these things to patients, yes, absolutely no problem. People get it, people understand it. Sometimes it's having the time to do that, but it's time well spent, because actually you've then got a patient that will tell that story to other people. So you get the message out very quickly that there's a reason why the door is closed. It's not that you're not there. I wasn't off playing golf. I mean, I was actually there in surgery doing a lot of work, but most of it was done remotely. So the practice didn't need to be open. You didn't need to take the risk.
To be honest, I came across several examples of inappropriate communication around DNRs and stuff like that. And I know that several of the MPs took them up very early on, but I think, you know, that was very, I think all that's been sort of clarified now, shall we say, in terms of what the boundaries are. And to be honest, I think it was just people who were poor communicators as much as anything else. But anyhow, so we're certainly very clear that that's not a policy that any of us would endorse.
No.
A blanket policy. Okay, thank you. So I've got Mike now who wants to come in. Mike Drabble.
Thank you, Chair. And actually, given the nature of the discussion, I think it is appropriate I actually declare an interest at this point as well, which I probably should have done earlier. Actually, is it okay if I do that?
Yeah, carry on.
Yeah, thank you.
I do later than sooner.
Yeah, I do work for a GP surgery for a day a week, so I think it's important to know that. Is it okay if I go ahead and ask a question? Or would you prefer me not to? Yeah. Okay, thank you, Chair. I think really going back to before the COVID-19 pandemic, you know, for very understandable reasons, GP surgeries were variable in their uptake of new technology, new methods to access patients. For example, using something like the patient access system, some GPs would be on patient access, and of those GPs that were on, some had more kind of options available to patients than others. And I'm going to go out of a limb and maybe suggest it strikes me that COVID-19 may have accentuated such already existing trends. So I'd like to ask, what can you do as a CCG to actually kind of move to eliminate some of these variabilities? Because, you know, I know all GP surgeons do their best on it. Some are just more experienced than others, but it would be unfortunate if simply due to the postcode you're in and the GP that you're kind of registered with, you don't have some of the same options as other people. So anything, any detail you could give on anything you could do in the future to try and kind of level that playing field would be very useful, actually. Thank you.
Thank you. Who would like to start on that? Sandy or Zach? Which?
Do you want me to come in?
Yeah, by all means.
Yeah, it's difficult. It's a difficult thing because general practices are individual businesses, and I you know, some people think that's a bad idea, some people think it's a good idea. My personal view is I like the independent contractor status because it lets you really advocate for your patients. So you're not controlled within the system as much. The downside of that is you get variability, and some practices are more up to speed with some of the technology than others. What we're trying to do as a CCG is almost sort of get a baseline. So we're trying to have an offer. I mean, part of it being that we've underinvested in IT in the past. It's always, we've never had the full investment that I think has been necessary. So what we're trying to do is invest more, but part of that is to sort of set a baseline so that you can expect exactly the same service from every practice and the same connectivity across the practices. But at the same time, what we don't want to do is slow down the practices that want to really be innovative and embrace some of the technology. And it's not just technology, it's probably the same with most things. So, I mean, if you look at a practice, depending on the partners within a practice, you'll have more specialist skills within that practice. So my practice, I used to be a partner in Woodhouse. We were a big practice. We had a GP who was effectively a senior registrar paediatrician, with myself who had a bit of experience in mental health issues. We had somebody who had experience in orthopedics. So there is a little bit of inherent variability at practice level, depending upon the skills of the individual GPs that are there. And it is difficult because I think it's around what's the accepted baseline. And I think overall in Sheffield, the quality of every practice is pretty good. But then you will get that variation across practices depending upon the skill mixes that they've got, but also depending, what you say, upon how they embrace IT and they use it. So I think it's trying to set a sort of minimum level, which is really important. And I think that's working with practices to do that, again, through the PCNs, through locality managers, to try and get everybody sort of up to that basic spec, but then also encourage others to share ideas to just gradually bring people up a level year on year.
Thank you. May I follow up, please, Chair?
Yeah, carry on.
Yeah, thank you. Yeah, fully accept the reasons for the variability due to the model of management of GP practices. But I suppose, I mean, this is probably not an answer you could give me now, but I'd just like maybe going forward some more detail on exactly how that process of levelling up can work. Because, again, I think it's important to say that some GP practices might be struggling, might be kind of falling behind on this just because they're struggling and they might need more support. It might not be due to an inclination that they don't want to do it. It's just with the amount of work they've got on, they feel unable. It might be not just IT, it might be management structures and management practices, because management practices can vary across. So look, I just welcome going forward, as I said, more detail on exactly how this levelling up process can work. Because even though I fully take your point that, there is a reason for this variability, I don't think it can be right that you could have two people on the road who are neighbours. One person has access to a whole set of facilities and can actually book appointments online, can access kind of various other services that are kind of self-referable. And when the next person can't, simply because of the GP practice to go to.
Yeah.
It's about equity as much as anything else, isn't it?
Yeah. It is. We might have a bit of an opportunity in that the IT support services a few years ago were moved out to a private organisation. Between you and me, it probably wasn't as successful as perhaps others envisaged it would be, although probably as unsuccessful as a lot of us thought it might be. So we've now got the service back within the CCG. And that enhances the relationship between the IT, and I'm not an IT expert by any means, so this is for me as well. So you've got that easy access, you've got the training that's available. We've also got within the PCNs practices at slightly different levels, and they're much closer, much easier for them to share ideas and level up, and real incentive for them to do it, because what they don't want are practices that are operating at a lower level, because it makes it very difficult for them to connect up and to work together and to share resources across practices. So I think these two things probably are a real incentive for people to do it, but absolutely accept there's still work to do. So yeah, it is one of our priorities, particularly around IT, but I do accept with all the other services. Well, it's very difficult to set a benchmark for general practice. What is a good general practice? And quite often you'll find that one practice is exceptional in one area, but maybe sort of average in another. I think the secret is to get every practice to that sort of average minimal level across all areas, and that's the job for the next few years.
Isn't there, before I bring in Sandy, isn't there something about equity of offer?
Yeah.
If you turn it round, it isn't just about the individual GPs and what they bring, but actually what the offer is to the community collectively. Sandy, I'm sure you wanted to comment on that.
Yeah, I thank you, Chair. I just wanted to say that I think you're right in terms of the pandemic has accelerated the use of IT usage and the way virtual working has been done in primary care. And I think what we're doing is at the moment is, again, learning from what we've been through and developing a digital strategy within primary care with our practices, which will enable us to understand what that baseline is, what is it that how each of the practices are working with digital technology and what will help. I mean, there are a number of programs and clinics that we're looking at. So for example, dermatology and taking pictures in order to get expertise comments on quicker than referring to the hospital. So there's a number of things we are looking at from a digital perspective, but I think you're right in terms of that understanding of the baseline approach in order to ensure it's equitable across the practices, and then see what can be done further and faster. But absolutely, the pandemic has accelerated this approach, and the CCG is very aware of that and very much wanting to make sure that we can continue with working with them to move it forwards and onwards as part of our digital strategy.
Thank you. Okay, Mike, yes? Okay, thank you. I've got Angela, and then I've got Lucy, and then Talib. So Angela first, please.
Thank you very much for answering all the questions so far. And some of the things that I was wanting to ask have been touched on already. You may have gathered that we are all worried and concerned mostly about access, and especially people who have struggled with the provision, especially I suppose at the beginning of the pandemic, when non-emergency things were put on hold, and obviously vulnerable groups that have had problems accessing especially telephone or digital kind of services. I think mine is going to be a bit of observation, comments, and some questions thrown in just to see whether I am making the right assumptions. I'm assuming that the pandemic has also, as well as throwing lots of things in this array, has also given the opportunity to actually introduce things like telephone consultation and video consultation that weren't done before. So it's like at the end of this, if there is going to be an end, hopefully there is, we will be able to offer patients a choice of how they can access the services to, speed up some of the services themselves. But of course, this is going to create like different, other people have asked this, it's going to exclude some people who find it difficult to access services in a certain way because of resources or because of language or because of their disability, etc. So I was wondering whether, and I'm assuming that there is, but is there a gathering of data of how the different surgeries in Sheffield are performing in terms, and what their needs are in terms of, IT or whatever other, because different surgeries will have different challenges depending of the demographics of their catchment area, I'm assuming. So in certain areas there'll be more older, elderly people. In other areas there will be more people with English as an additional language. And things vary over time as well as people move around. So I'm wondering whether that data is gathered and then, so needs are assessed and addressed eventually. And also I was wondering, in terms of those patients, and I put myself as one of them, who had an appointment, was supposed to make an appointment with their GP back in March and never got around to it because it wasn't urgent, but it's now nearly a year overdue. And I'm still not done it because I feel I don't want to put pressure on the NHS. How we, nobody's called me from my surgery to say, oh, by the way, you were supposed to come whenever. So how are we addressing those people like myself who are too, worried about overburdening the services when it's something that wasn't urgent 8 months ago, but might be something that needs to be done now, and I've still not bothered during my surgery. So how do we make sure that I don't fall through the net and other people like me don't fall through the net?
Okay, thank you. Can I just clarify your question about needs? You mentioned IT. Is this about IT, or is it just generic in terms of sort of people accessing services?
No, it's about people accessing services in different ways depending on their needs, but also about the needs of the surgeries that will be different in different parts of the city.
Thank you. Just wanted to clarify that to try and help out you guys. So the two questions there, one is actually about accessing services, and the other is about actually catching up with people who haven't been attending general practice and now where there's a big time lag. So who's going first? So Sandy, you were about to say something.
Thank you, Chair. I wanted to just tackle the first point in terms of the collection of feedback. Basically, we meet and work with the practices and the networks often. We have a dedicated primary care team or portfolio within the CCG who are in regular communication with the practices, and we do collect the feedback at a number of forums to ensure that where they do need assistance and support in various different areas, that to work with them in order to look at what we can do for them as a whole. And then as what was said earlier about learning and sharing best practice and learning across the practices as well, so that there is an amount of information, more qualitative in terms of feedback, that we are working with them and seeing what we can do. I'm sure Zach will want to come in on the next point in terms of those people who regularly should see their GP prior to COVID, those who have had long-term or who have long-term conditions and who are known to practice to have regular checkups. They are being contacted by their practices to make sure that their health is maintained throughout the pandemic. So those people will not be lost through the net. Those people obviously who they don't know, you know, who should have come but because of something but are not necessarily known. We have tried all the communications that we've said before in terms of encouraging people to still contact their GPs, to still make sure that their appointment, you know, they do book their appointments, because as we've said right from the start, you know, primary care maintained their open door. You know, they were still working and very much still needing to see patients during that time, albeit in a very different and virtual way on a number of occasions. So, you know, it's I think those ones that we've known, we've continued to make sure are seen, and the communications are what we've been able to do in terms of making sure people still access. But I'll just hand over to Zach, because from a GP perspective.
Yeah, I think there's two bits. I think the bit around the sort of kit and the access and stuff, I think all the practices were asked what they need, and we, although there was a delay at the beginning of COVID because you couldn't get the kit, within a couple of months we had all practices up to speed for remote working and a system called Accurate, which is how you can do your remote consultations. The practices are quite good at coming forward and saying, you know, they understand their populations, they understand what they need to manage the population. So what we tried to give was as much flexibility as we could to the practices. Some of the major issues we had and we couldn't solve were around the sort of, and this is, you know, technology again, which is not my expertise, but the bandwidth. So we had a lot of practices that even if you give them all the kit, they were still getting that little circle of doom that we call it, where you get it sort of rotating around the screen. And that's a major issue when you're trying to do a consultation, as you can imagine. But I think that's more the basic infrastructure around the broadband that is delivered to each practice. And I think it's a bigger issue about infrastructure to try and correct that. And we are moving towards that. So we're trying to make sure that the cabling they've got into practices actually gives them that extra bandwidth that lets them sort of manage that. But with remote working, we also looked at the 4G and then the 5G capability. Again, in Sheffield, with the hills, it can be a bit of an issue. So again, we tried to use a bit of flexibility. So it was a bit of mix and match to try and find solutions to the problems the practices identified. All the practices within the primary care networks have the demographics. So we give them all the public health data, we give them all the demographics of the populations. And they're encouraged to actually look at the specific needs of their populations. So the sort of tailored offer that you get from your PCN over the next sort of 5 years or so should start to much more reflect the needs of the populations themselves. Again, COVID accelerated some of that, but it also probably held back some of it. So I think there's still a bit of work to be done there. Final bit about patients coming. I mean, a real issue. I think there were some patients who were brilliant, but I wish they weren't so brilliant because they didn't come when they probably should have done. And I'm now seeing patients that have got significant morbidity because they should have probably come and seen me or contacted me 6 months ago. And although we tried to encourage them, I think some people for various reasons did that. Some of it was fear of COVID. So people didn't want to come and see the GP because they thought they might catch it from the surgery. Some of it was genuinely that they didn't want to bother us. And again, that was trying to get the message out that we are open for business and we're there if you need us. The bit around your sort of regular reviews and stuff, all the practices prioritized. So they went through their list of patients. You can do it electronically and you can identify who your highest risk patients are. And these patients were invited in and had their reviews as normal. Most of the practices are now getting to the point that it's the lower risk patients that they're now approaching. So you should hear from your practice in the next couple of months and be reviewed. But what I would say to anyone is if you're not sure, just contact the practice and ask, you know, and they'll tell you, yeah, you've not been reviewed because, or, you know, obviously it can happen occasionally, oh, you know, you're slipped through the net. So I think it's really important that if people aren't sure, contact the practice, ask the reception, they can check it on the screen and they can tell you very quickly.
Thank you. Angela, was that, did that answer all your questions? And your...
Yes, thank you. And thank you for reassuring
yes.
reassuring us about the, you know, the gathering of the picture from the different surgery. I mean, I assumed that was what was happening, but I didn't want to make an assumption.
Okay. Thank you for that then, for the questions and the answers. I've got Lucy, then Talib and Martin, and then Martin. So Lucy first, please.
Yeah, so I've got two questions, and the first one relates to something that Angela's just touched on in her question around collecting information about access for different people. But just to hone it down a little bit more, I was wondering specifically what assistance and support was being provided to GP surgeries to help them understand and consider how they might need to adapt practice to meet the needs of deaf patients. It's a recurring theme that comes to us time and time again. And I wondered in practical terms, what's being done to help people think about that issue and address it at the moment. And the second question relates to care homes. So particularly earlier on in the pandemic, we had some feedback about sort of variable GP input to different care homes. So different care homes experiencing different things and some confusion around what they could expect in terms of GP input and support. And I was just wondering what that picture looked like now and how equitable that service was. I guess firstly, the equity between if you're in a care home or if you're not in a care home, how equitable is your GP access? But then also between different care homes, is there equity between those?
Thank you. Two good questions there. One about access for people who are hearing impaired and other about care homes, which I was going to ask as well. So who would like to start on those? Oh, sorry, you appear to get a bit of a grilling, but we're all obviously really interested. We want to get the record straight in particular. So you can actually go and have a drink of water or something like that if it's getting a bit much for you. But we do love you.
I can answer the care home one first. I think some of it was confusion probably around. It's that bit about you need to put yourself in the position of being able to make a judgment about a patient. And practices were told to minimize the contact. So I think probably sometimes that was variable. So some GPs feel more confident than others in using the remote access. And so I think there was a bit of confusion around that. You know, the GP normally would come out for that, but he's speaking to me on the phone, or he's asking me to take a picture, or he's doing it in a different way. So I think there was probably a bit of confusion there. We quite rapidly were aware that we had to try and get GPs much more wrapped, and not just GPs, but community services and support wrapped around care homes. And we already had most of our nursing homes were covered by an enhanced service. So you had a named practice that covered your nursing home. We very quickly rolled that out so that we had coverage into care homes. And that's now been adopted within the PCN network. So all of the care homes should actually they should know who their practice is, who their GP is, and the sort of support that they should expect. It will have been variable, and some of it will be because of different behaviours at practice level and different ways that practice do things, but also we were getting practices that were really getting short of staff very quickly, and we're struggling to particularly get clinical input. So I think I would accept that it would be a variable offer. What we've tried to do now that we're getting through COVID is really try and sort of clarify what that minimum offer is. And the feedback we're getting from both care homes and nursing homes is that they do feel much more supported, not just through the practices, but the council did a huge amount of work to try and make care homes and nursing homes feel supported, because I mean, it was horrendous. You know, you can imagine an outbreak in a nursing home where, you know, you've got staff that are looking after people that almost become like relatives. It's a very close relationship they develop. And you were suddenly finding overnight that there were 4 or 5 deaths. I mean, it was absolutely horrendous. So we also tried to put some psychological support into nursing homes, bereavement type counselling, because effectively it is a bereavement for a lot of care home staff when somebody that they're looking after dies. But like you say, it would never be perfect because of the timescales that we're trying to introduce it. And it is something that we're certainly going to enhance in the future, and largely through the primary care networks. It is one of the key areas for the PCNs to look at. But again, through COVID, I think it was accelerated. But perhaps when things are accelerated, some places go quicker than others. So you then get that variation, which is unacceptable and unfortunate.
So could you clarify then the sort of what the second part is, well, not the second question, but the second part of that question about what the current arrangements are, and are those going to stay the same going forward? Yeah, so within the primary care networks, each care home or nursing home has got a named GP and usually a named practice within the network that looks after them. Clinically, it makes a lot more sense because you build a relationship with the staff, and you get, it's that continuity of care bit, you get to know the patients. And that is funded within the primary care network. It's an enhanced service, so it's an additional service to your GP core contract. And all our networks have signed up to that. So we now have that coverage for GP care across all the networks. But we've also got a lot of input that we've put around the council support, but also end-of-life care. So we're working with St Luke's and with the teaching hospital, we've put a lot of end-of-life care support into nursing homes and care homes, and we did some education events called ECHO. I don't know what ECHO stands for, but it's an online education, and it's largely around how to manage patients in end-of-life situations. Part of that being your DNA CPR, how it should be done properly, you know, how it shouldn't be done improperly. And again, we're getting really positive feedback from the care and nursing homes that they valued that input. So thank you. That's a really important clarification, isn't it? That, you know, in terms of what the situation is now, and that's useful for all of us and for the public actually to know that. The second question, Lucy's question, was around people who are hearing impaired, and obviously the access through technology is much more complex in those situations. So any comments on that, please? Difficult for me to answer specifically around the deaf patients. I mean, we do encourage practices to try and adapt to the populations, and we support them to do that. I'm not cited around specifically deaf patients, other than it would be part of that overall offer for any patients that have got disabilities to try and help practices to support that group of patients and manage them in the best way they can. I don't know, Sandy.
Yeah, I was going to say we've actually done a deep dive into some of the feedback and engagement with a number of different communities, and one of them being the deaf community, and looking at how they accessed the services prior to COVID and then during. I'm sorry to say I haven't got the detail now, but we have undertaken that because it was something that was quite nationally discussed and brought up, and it was certainly something that we wanted to understand a bit better at a primary care level. So we did do some work on that, and as Zach said, it is down for the practices to be able to ensure that everybody from all communities and disabilities or what has had access during this time. But like I said, we have got some detail in terms of that deep dive. It's not perfect, but it is certainly a good foundation for us to work on and improve them, improve the access to services. But certainly something that I'm happy to share at a later date.
How would you do that as a matter of interest? What's the cunning plan in order to be able to, I know you have to work with practices, but I was just wondering whether what the strategy was basically in order to do that, because it's obviously a big issue that's been around for a while, and again has been exacerbated by the shifts as a result of COVID.
Well, I suppose the strategy at the start is engaging with that population first to understand what the issues are, what the areas of concern, and where they had difficulties. To understand that, then we're able to put things in practice with the practices themselves. So it really is accessing those communities in order to get that information and work with them, but very much being committed to do that. Like I said, it is in our plans, and we have done some already, but like I said, unfortunately, I don't have the detail to hand with me, but it is something that we are very much committed to doing.
So Lucy, were you indicating you wanted to come back in?
Yeah, sorry, my hand disappears into the background. It's quite
mine does.
It's hard to put my hand up. So yes, thank you for that. Firstly, just quickly in relation to care homes, I'm really pleased to hear that they've all got those allocated GPs now. I wasn't quite sure if that was the case or not, so I imagine that makes a significant difference. In relation to the point about deaf patients, I think there is quite a lot of intelligence there, both pre-COVID, and there's also been some picked up during COVID through ourselves and the CCG. So I guess really what I'm trying to pin down that I'm still not quite clear on is how practically we can take what we've already been told, actually, that information is there about what works and doesn't work for people to a large extent. It's how that's practically translated into whether it's, I don't know, a toolkit or something to help GPs understand the implications of that information and how they need to adapt their practice. So I'd just be really interested to hear about any future plans to actively work on that. I appreciate what you're saying about it's still kind of under consideration and you won't have had the opportunity to do that as yet. But yeah, be happy to talk to the CCG in the future about that.
Very much appreciate that.
So did you want to come in on this point? Oh, I'll just add you to the, okay, because I've got others as well, but if it's this point, I'll take you now.
Yeah, it was just a point of clarification, if I can, Chair, thank you. In terms of GPs covering care homes, I mean, it sounds incredibly sensible, but if I was, or, you know, relative was a patient going into a care home who had had a long-standing relationship with a GP that they trusted, and they wanted to remain with the same GP practice, obviously assuming it wasn't geographically impossible. It is, what I'm really asking, I suppose, is does the patient have any say in this, or are they automatically taken over by the other GP's practice?
The patient has the choice. I think it's fair to say that we encourage patients to move to the practice that's covering the care home because it does enhance the quality of care. But if that patient is moving to a care home within the geographical practice area, then they do still have a choice of GPs within that area. So it is up to them. But I'd be wrong to say that we don't encourage people to move, because it makes sense from a logistical position. But yeah, I mean, the choice is there if people want to use it.
Thank you, that's clarified, thank you.
Okay, thank you. I've got Talib now, please.
Thank you, Chair. My couple of questions, other colleague asked and been answered, but I've got one particular question regarding, you know, that's in Muslim faith. I mean, usually surgery, they are fantastic. They help, you know, but during the COVID, is Muslim faith people, they feel have faced difficulty to get the cause of death. I mean, the people who are long terminally ill passed away at home, and it was usual practice if GP physically checked the patient within a week or 2 weeks. So they were used to issue the cause of death, whether it's weekend or during week. But now it's not happening. It's really difficult time, and it's difficulty, whether it's the GPs, they are not attending the patient, they are not physically seeing the patient in that period. So I don't know whether you are aware of this issue. You got any information to update the certain community members?
Obviously, a very sensitive issue. So yeah. Any comments? I mean, you know, I can see how difficult. Yeah.
It is difficult. That there was also a mismatch between national guidance, which is around the fact that you shouldn't be seeing patients unless you absolutely have to, and like you say, the death certification, where you ideally should have seen the patient in the run up, and some of it was, you know, what is seeing a patient is a telephone call, the equivalent of a consultation. So I think it's fair to say there was confusion at the start. I've put a lot of guidance out around end of life care. Sarah Mitchell, who's our clinical director, works with me at CCG, is a real enthusiast around end of life care, and particularly been very culturally sensitive when it comes to end of life care. And part of that is thinking forward into the sort of death certification process, and how that's sensitive to the religious beliefs and fits with whatever the arrangements would be after death. So unfortunately, it sounds as if it's not working in every case, but there is guidance there that is really supposed to support and help practices. I would be interested in the cases that you're talking about, because we can actually talk to the practices, and we can try and support them, and we can point them towards the guidance that's there, if that's helpful. So I mean, if you want to contact me outside the meeting and just give me some of the details, I'm happy to follow that up. But the guidance is there. We've worked with a local coroner to actually get some guidance that I think now probably is safe, but also accepts that you do have to be culturally sensitive in how you manage some of these situations, without actually putting anyone at risk. So the guidance is absolutely there, but it sounds as if maybe it's not quite got through to certain practices, or it might be that these are instances from the past, but the guidance has certainly been there for the last couple of months.
Talib, can I suggest that you email through Emily, and Emily will pass on your email.
Pass it on, yeah.
Yeah, if you want to sort of give a bit more information about the practice and a couple of the case studies, then those can be passed on. Okay, is that okay?
Yeah, that's fine.
Yeah. Thank you for that. Martin.
Thanks, Chair. Thanks for the CCG colleagues for coming and answering our questions, putting up with us. So I've got a couple of questions, if that's okay, but they're not too long. So
just let you know, this is the last questioner. So last but not least, Martin, I'm sorry to interrupt you. Please go ahead.
Thanks. So rough sleepers and homeless people were briefly mentioned in the report, but I just kind of wanted to ask, what has accessing primary care been like for rough sleepers, and how that's primarily been done, whether it's been by referrals and then in person, because I'm conscious that they might not have the technology themselves to do that. And whereas they probably were doing, there was probably quite a lot of walk-ins. I know the walk-in was quite well used for appointments with rough sleepers, and that obviously affects some GP surgeries much more than others. So there's that. I was wondering how community pharmacies have been supported by the CCG throughout this, because I know of an instance of a community pharmacy that provides, I think it's methadone, basically, and they normally receive funding for that, but there was actually a big funding shortfall after the first lockdown. because they would get funding per administering the dose, but because of wanting to reduce the risk of spreading infection, one dose would be done in person and then several more would be given to them in line with guidance. But because they were paid per dose then that was administered, they were actually receiving like quite a massive shortfall in funding. So I wonder if CCG is aware of problems like that and how they've been supporting community pharmacies.
So maybe community pharmacy first. We don't directly commission from community pharmacy services. As a GP, I'm aware that the current contractual arrangement with NHS England has been changed, and I think a lot of community pharmacies are struggling. They've had a huge amount of cut to the financial package. What we are trying to do is we work with them to support them. So we've got good relationships with them. The practices have. We work with the local pharmacy committee. But beyond sort of support, it's difficult in that we don't directly commission. So it's very difficult for us to do anything funding wise. Other than some of the ideas in the future around PCNs, is to try and get community pharmacists working within PCNs. And then it may be an opportunity that we can fund some of that through the PCN network enhanced service. That's a sort of network agreement. So we're trying to encourage networks to find ways of working more closely, and that extra funding might actually give a bit of support. But I do feel for colleagues in community pharmacy because they play a huge role. My personal view is the current contractual arrangements nationally are not acceptable. They've tried to take too much funding out, and I think many of them are struggling. And if they're lost to the system, it is a huge loss. So that's that one. The other bit around rough sleepers and homelessness, two aspects. We did a lot of work in trying to offer accommodation. So there was accommodation through effectively hotels that were not being used. And that, my understanding is that's been extended up until the end of the financial year. We used some sort of innovative ideas around that. So almost the opportunity and actually having someone in that environment was to give them the opportunity to try and engage more with services. So what we working through a local practice, Devonshire Green, who have always been the sort of local experts in managing patients with homeless patients and rough sleepers. They've worked with us to actually offer support into some of these hotel accommodations. Now that doesn't cover everyone because there are still some rough sleepers who choose to rough sleep, quite often because of other underlying conditions, or sometimes some of the restrictions that have to be imposed when you're in some sort of hostile type environment. So again, we try to offer enhanced support, largely through the practices that are local experts within that. So we offered extra funding, extra GP capacity, and also the council worked very closely with us to actually offer that support. So again, you know, it's not perfect, but I think we offered more support than probably a lot of other areas. And actually we have evidence to demonstrate that the actual incidence of COVID amongst that group, which obviously are a very vulnerable group, was minimal. So I think there is some evidence that the support worked.
Thank you for that. I was just thinking while you were talking, actually, I mean, community pharmacy is possibly something we need to think about adding to our work plan, guys, because, you know, we all believe they're critical and there's not much we can do to shape them locally. So we'll talk about that in the next item. Just now, for anybody who's not had an opportunity to ask a question so far, last opportunity now for questions or comments. Gary, you've had an opportunity. Anybody who's got a burning question or comment before first of all, thank you very much to Sandy and Zach for being in the hot seats today. And I hope you, I know it's tough for you, and thank you so much for your responses to all our questions, but you can tell how passionate we feel about it. And we think it's really important, and we're also ambassadors with our communities. And we think it's really important that we do give you an opportunity to challenge some of the misunderstandings and so on that are out in the communities. And my view is that a lot of this has come from the early stages of COVID, because the message that got out was don't go to your GPs, and the subsequent messages and so on haven't actually being communicated to the same extent. So maybe that's a big challenge for us all. Just in terms of summing up on behalf of the committee, I think it's really good to hear that unequivocally that general practice is open for business. And for all the questions we've asked you this afternoon, I think, you know, we're satisfied with those responses that is definitely the case. So thank you for that. We're also very pleased to hear about the arrangements for general practice support for care homes and nursing homes, because that's been a concern of all of us. And so that's really good to get a very clear message on that. And we thank you for that as well. There's also some issues that I think we all agree on from what you've said and from what come up today that probably need a bit more work. And there are some issues around the digital divide. And that's an issue for the council. I think it's an issue across the city, and at some stage there needs to be a conversation about that, not just in individual institutions, but actually for the city as a whole, because I think we're actually talking about the same communities. So we need to come up with a collective solution to the digital divide. And there's still some issues I think that need to be resolved around health inequalities and how people access general practice. That's true for all our services, but I suppose the bit about access is actually exacerbated by what we've heard in terms of the acceleration of technology, introduction of technology and so on as well. So I think that's a big challenge for you at the CCG, and we certainly want to, obviously you can't respond to that immediately, but we want to actually, we'd be interested in seeing how you respond to that challenge, basically. Yep. And I suppose the final thing is communication, that's been a consistent theme throughout this whole session. Communication both in terms of to the public as a whole, but also between local practices and the people that they serve. Because I think we've had a number of examples where that's perhaps not worked or perhaps needs refreshing and so on as well. Also, I think I would say on behalf of the committee that would be one of our recommendations to you, as it would be to our services as well, in terms of ensuring that is constantly dealt with. It's not a one-off, is it? It's got to be a iterative process. So those are the key points I've heard from today's session. Is there anything that I've missed that anybody else would? I mean, there's obviously the issue in terms of health inequalities that's been highlighted around to deaf communities as well, and obviously you're going to do some work with Lucy around that. Any other big points that we would like to make or feedback collectively? No. So I'd just say on behalf of the committee then that we are very reassured as well, and we'd like to reassure the people of Sheffield that you know, we have got good primary care services in Sheffield. They've been challenged by COVID, but they're still open for business. And, you know, so thank you very much for the session today. Don't go away, the rest of you. I'll let I'll let Zach and Sandy go and sit down a dark and quiet room for a while to recover. Just to mention that we have had a message from Nikki Doherty. She had tried to get a message to us giving her apologies because she's had to go to a funeral this afternoon. Yeah. So nice to see you both, and I'm sure we'll see you again, and have a good Christmas and New Year. And thank you to all your colleagues for all the fantastic work that they've been doing during the pandemic and are continuing to do. So thank you on behalf of us.
Fantastic. Thank you.
Thank you very much. Thank you.
Thanks.
Thank you, everybody, for those cracking questions and so on. I thought that was a very lively session, and we've given some very clear messages as a result. Just quickly then on to item 8, which is the work programme, because that's usually when we've got a longer agenda, that's usually the item that falls off the end when we're all exhausted having spent 2 hours discussing a topic. So it gives us an opportunity then to have a quick chat about that. Emily, do you want to introduce it?
Okay, so you've got the work programme as it stands at the moment. There has been something else has come up since that was published, following on from the October session we had on the strategic review of adult social care and fees for care providers. The team are planning to take that to Cabinet, the final outcome of that to Cabinet in March, and have suggested that they could bring it to scrutiny beforehand to the February meeting. so we can add that to the work programme as well. There are only 3 meetings left of this municipal year, so it's over to you really. If there's anything you want to comment on what we've got on the work programme, or particular issues you'd like to highlight within it, over to you really.
Any comments, please? Sue, Councillor Austin.
Thanks. I did suggest in the email, I did wonder if we could find somewhere in the programme to look at provision for dentistry, because I know dental services have been very severely impacted, and I just thought that might be worthwhile if other members agree, trying to fit that in somewhere, if that's appropriate, Chair.
I'd second that. That's something that we hear about relentlessly.
Sorry, who did somebody comment on that there? Oh, sorry, it was.
Sorry, Kate, it was.
Yeah, sorry, Lucy, I missed you.
Yeah, sorry, it was me. I was just saying I'd definitely second that. That's dentistry is something we hear about relentlessly. It's really impacted on people.
Firstly, I think dentistry has been a problem for quite some time anyway, hasn't it, in terms of access? So I'd support that as well.
Yeah, I'd support that too.
So dentistry's moved up the work plan, and the other issue is obviously community pharmacies as well, which sounds quite urgent as well. So I'm just trying to think about looking at meetings, blah, blah, blah.
Okay, well, while you're looking at, I think the other thing that people often forget about dentistry is, I think a lot of us think of dentistry, it's about where you go if you've got a toothache. I think what a lot of people forget is lack of access to dentistry has some can have some very major health implications for later in life. So I think it really is important. Sorry to catch it again, but I've been very quiet this meeting.
You have? Yeah, you have. You're right.
I'm so over-zoomed at the moment.
I wonder whether or not we could fit dentistry and community pharmacists into the. Oh, we've got the. They want to bring the fees paper back as well, don't they, in February? So we've got 2 updates in March. Can we have a look at it? But so the dentistry is top of the list. I think the impact of COVID on hospital waiting lists has moved down the list, but we've got community pharmacies are coming in overtaking as well. So we'll have a look at the agenda and see what we can manage. But we've got the clear message that dentistry is the #1 priority. Is that Jane? You wanted to come in?
Yeah, I completely agree with that. I have to declare an interest because my son is leading on the communications for dentistry and doing all the work on that. So trying to get it pushed forward. I was wondering about, should we do anything about the rollout of the vaccine, do you know, and how make sure that this is done, do you know, equitably across all the care homes? I was just wondering if it was something that we should be kind of keeping an eye on, or it's on our radar. So I don't know.
I agree with you. We've got lots of the issues.
It's quite a hot topic, isn't it?
Yeah.
And it could have an impact on how our communities unlock, in inverted commas, do you know? So, and the effect on all the other services, if you've got certain areas which are kind of seem to be getting people vaccinated quicker than others. So I was just wondering if that should be something.
I mean, we are trying to, we're happy to respond. It's just a question of
time. Yeah, no,
yes,
I completely agree about the dentistry and the pharmacy. I think it's
right.
Really,
okay,
really
but we can add that to the long list so that sometimes if something drops out as well, we can we can substitute. So Emily, if we could just take a note of those as well, and I think we've got a clear sense of priorities and a bit of frustration that we want to do more than we've got time to do as well, which is good, rather than sitting here twiddling our thumbs and so on. So any other comments on the work plan? No. Okay. Well, we'll try and amend accordingly and see what we can fit in without trying to cram stuff into an agenda, which is just not going to be doable, because we don't want another planning meeting, Jane, do we?
I don't set the agenda.
Well, we can control it. That's
part of it.
Okay.
He doesn't set it, but he gives us an unfortunate timeline.
Yeah.
I've got no matchsticks left.
Do you know what? I'm not kidding.
No, we're not going to rerun, so thank you very much for that. So that's the work programme then. So that's the end of the meeting then. The next meeting will be on the 13th of January. Some of us are meeting next week for Overview and Scrutiny Management Committee, but you know, for the rest of you, I hope you have a fantastic Christmas and New Year festive season, shall we say, and I look forward to seeing you in the new year, and thank you ever so much for all the hard work and the great.
Same to you, Chair, and thank you for being so
Thank you,
kind.
and happy
Thank
Christmas,
you all.
everybody.
Happy Christmas.
Keep safe. Keep safe. Keep
Bye.
safe.
Bye.
Bye.
All right.